Hello, and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to go through another article, or at least the abstract of it, in the International Journal of Osteopathic Medicine. The article title is Assessing the Effects of Manual Therapy on Pain in Patients Living with Persistent Non-Specific Low Back Pain, PNSLBP, which evaluation criteria and measurement tools used in randomized controlled clinical trials, a systematic review. So very long title. What you really need to take away from this is that it's a systematic review, which means it is a question posed to assess and gather information from previously existing literature. Maybe research papers is a reasonable term, maybe literature is a reasonable term. Depending on how you frame your question, you may be looking to do a systematic review of systematic reviews. You may be doing a systematic review of trials that are not randomized. You may be looking for trials that are done in a very, very narrow way. Either way, you're setting criteria for what you're going to include in your paper and what you're going to exclude from your paper or your systematic review or your scoping review. So systematic reviews and scoping reviews are your two big meta-analysis types. That's what you'll find when you're looking at meta-analysis. So a meta-analysis is a study of studies, but it's not really a study of studies. It's really a question posed with appropriate inclusion and exclusion criteria to essentially assess what already exists in the printed format with respect to what many would call scientific literature or scientific research papers. You can use different terms, but basically scientific papers is reasonable. Okay, so I'll read the highlights and then I'll attempt to work through the abstract. The main point here, to give you a bit of the punchline or point in the direction of the punchline, is we're going to be able to some degree to line up the axiological outlook of osteopathy as a profession by examining the research that it does. And the way that this is done is through looking at the tools that they use to assess clinical outcomes with non-specific low back pain, persistent non-specific low back pain. Okay, so the highlights here. There is still considerable heterogeneity in the measurement tools used to assess the management of manual therapy patients with persistent low back pain, aka there's a bunch of different tools that people are using to assess the management of patients with low back pain. The majority of the measurement tools were classified in the life impact core area in form of self-administered scales or questionnaires. You're asking people how your therapeutic intervention is impacting their life. So they're forming the answers. Now, some of these will be highly bound, as in Likert scales or weighted scales, such as strongly disagree, disagree, neutral, agree, strongly agree, stuff like that. But they're still self-report. So you're not identifying things that other people are going to have an easy time agreeing with, or in another term, find as an objective scale. They're much more subjective scales. You're asking about patient experience. Final point of the highlights, trials are still needed, particularly on the impact of manual therapies using biomechanical markers, making it possible to evaluate patients in daily life situations. So essentially, maybe we need to look at other measurements as opposed to, did you like it? So a lot of these self-administered subjective questions are, did you like it? Do you feel like it's doing this positive thing to you? Something along those lines. Okay, so to read the abstract, to identify the evaluation criteria and measurement tools that are used in randomized controlled trials to assess the effects of manual therapy on pain in adults living with PNSLBP. Methods, RCT, randomized controlled trials, were included if, this is your inclusion criteria. So if participants were adults, 18 to 65-year-olds with persistent non-specific low back pain, PNSLBP, experimental group received manual therapies, osteopathy, physiotherapy, and chiropractic, and they had been published in English or French since 2010. The search was conducted between May 2021 and April 2023 using the Cochrane Library EBS co-host, Embase, Medline, PubMed, PED-RO, Pedro, Science Direct, and Scopus databases. 3 independent reviewers have checked eligibility. The Pedro scale have been used for quality appraisal. So they're telling you, even in the abstract, there's a very specific methodology that they followed. So if you wanted to do the same thing, you could limit your search to things that would have been available in that time frame. The results. The 29 studies included 131 measurement tools were identified in 3 main areas. 76% of the measurement tools were related to life impact, which 24% related to pain intensity and 23% to functional difficulties, and 24% were related to pathophysiological manifestations, 8% of which related to the range of motion. Okay, so when I say axiology, axiology is the value or value judgments of the researcher in the case of a scientific investigation. So when you do a systematic review, you are going to be able to identify to some degree whether or not there are consistent values and value judgments between researchers, or if there are inconsistent ones. Now, when you see 131 different tools in 29 studies, it's a lot of tools. Now, a tool essentially is what one would probably be able to term as a validated measurement approach. Now, that validated measurement approach is usually a questionnaire of some form or a checklist of some form. Validated meaning that people have made a case for why it does what it says that it does. Oftentimes, when people who did not create that measurement scale, that measurement tool, that checklist, use it, they may either use it in an inappropriate way for the wrong case, or they may need to adapt it and not adapt it. They don't necessarily do the work properly. So oftentimes the tools are possibly misapplied, so the validity argument falls apart a tiny bit. The tool could be valued or validated for a particular use, and then you use it slightly off angle. So I can't see that here necessarily, but I can point to that as a relatively common phenomenon. So you see 131 different tools that could tell you superficially, if you just scratch at that there is not a consistent value structure between researchers within hands-on professions. Now, this doesn't point specifically to osteopathy, it points to physiotherapy, osteopathy, and chiro. But what you see is across those 3 professions and research that's been performed with a wide variety of measurement tools that you actually find a lot of these researchers are asking about life impact. They're asking more about the experience, the subjective side of the outcomes of hands-on therapeutic interventions. 8% were related to range of motion. That's not a lot. So fundamentally, what we're starting to see as a pattern flowing out of available research that falls into chiro, osteo, and physio, that the researchers are asking people questions about, did they like it? How do you feel? It's much more of a subjective research area. So when people say it works for persistent non-specific low back pain, if they're saying that, odds are they're saying that the people that received hands-on therapeutic intervention are telling them they liked it. Now, there's more granularity needed, there's more detail needed, but the overarching phenomenon is that if somebody says it helps people with persistent non-specific low back pain, they're probably anchoring that on the result says that these people told the researchers they liked it, not that it improved range of motion, not that it improved function. There are functionality questions in there, but it's probably based on things I've seen across time, asking, was it easier for you to load the groceries in the car? It's like, well, what do you mean easier? The person's going to say, if it didn't hurt, yeah, it was easier. Did it take them more trips? Was it lighter loads? What was it? Because a lot of times people are over the span of having discomfort, pain, functional impediment, they will adapt and improve the outcomes by changing their behavior. So that's a tough one. I'll read the results, the conclusion rather. Most measurement tools focus on pain intensity and physical functioning using scales and questionnaires. 2 perspectives must be considered: responding to current recommendations by standardizing the measurement tools relating to life impact and pathophysiological manifestations, and using biomechanical markers, making it possible to evaluate patients in daily life situations. So that statement is pointing in the direction of the value judgments of the people who did the systematic review. They're saying it's going to be valuable to standardize the life impact or the pain intensity scales, because if you standardize it, then across a broader amount of research, if I then want to do a scoping review, it gets easier for me to extract the data because it's on the same scale. That ignores the reality that depending on the question that I as a researcher am asking, I may need to use a particular measurement tool or measurement scale to get to the thing that I'm trying to measure in a valid way. But if I preferentially aim to do scoping and systematic reviews, my life gets easier as a researcher if everybody uses the same scale. The ability to apply the data broadly improves if everybody uses the same scale. So both phenomenon are correct, both phenomenon co-occur. If I like the perspective of the systematic reviewer, then I want everybody to use the same scale. If I like the perspective of the researcher as an individual or individual group, I'm trying to find an answer to a specific question, I'm going to use this tool or I'm going to develop this tool. They're both fit for purpose. They're not fit for one another's purpose. So there's a bit of conflict in value judgments there that's seen. But you can see the people who did the scoping review would prefer if everybody was using the same scale. The thing that does seem to have some value broadly with what the systematic reviewers are saying is to use scales with pathophysiological manifestations. So that would be things like alterations in heart rate, alterations in blood pressure, alterations in respiration. If there are internal functional measures such as blood tests, maybe we want scales that would identify that. Once you start to break the skin barrier and try to do physiological testing, things get harder, more expensive for researchers. The other deal is that things like range of motion or physical measurement on a standardized scale of daily life situations. So ADL, or activities of daily living, there are tools that exist, probably of highly varied quality, but it can be done. So the thing that this all lets me point to is that within hands-on manual therapeutic professions, there seems to be a general trend that the professions value the subjective feedback of the patients because that's what they're asking them about in research settings. Now, it doesn't absolutely mean that. It could just mean that it's easier to do research in that fashion. Those tools are easier to administer. They're less expensive to administer. They have issues with subjective reporting. So normal subjective reporting issues are that the patient or the person doing the report, the subject of the research, is going to respond in a way that they think the researcher wants to hear or that they think will not get them kicked out of their preferred social group. So there's essentially what you would term a social desirability bias. So socially, you are going to feel pressure and respond to the researcher in a way that you think the researcher wants. You're going to try to behave socially desirable in that situation. Same thing with respect to how you would answer when considering your social group or your preferred social group. You're going to respond in the way that's essentially orthodox to that group. So subjective reporting has issues, but it is less expensive and easier to do. So this doesn't immediately point to the broad professions contained under the manual therapy umbrella preferring patient experience over everything else, but it points for further investigation in that direction, and then say as the ability to build a prediction or build a hypothesis. If you consider how practitioners interact with the general public and the types of questions that they'll ask them with respect to feedback from treatment, how do you feel? Did you like that? Is that too much pressure? Is that not enough pressure? You're asking, because you can't identify or measure the subjective information, the internal state of the patient, you'll ask for feedback. So that positive feedback may be predicted to allow a practitioner to feel as though on the business side that they're going to have less attrition, more return patients over time. So because there is a market force at play, and that market force involves the internal state and preferences of the people who present for treatment, you can see a reasonable case for why practitioners would value the internal state and preferences of the patient, and that may show up in research. It may show up in research because it's easier to do with a subjective scale. It's less expensive to do with subjective scale. There may also be the market pressure on the business side of the value of the patient experience. Whereas if you're trying to make claims about what osteopathy, what chiropractic, what physiotherapy do for actual alteration in function, those are the wrong scales. So currently, at least from this scoping review, which only included 29 studies, there seems to be a trend pointing in the direction of a general preference for measuring the subjective experience of the patient as opposed to the objective, observable, consistent observations or measurements of what happens pre and post treatment, or the difference in functional things such as range of motion, such as force production, such as tidal volume, such as max inspiration or expiration volume for respiration, things like that. There so far, at least from that one systematic review, seems to be corroboration of pointing in the direction of practitioners in hands-on therapeutics valuing the patient experience that they cannot sense. So I cannot sense the internal state of another person. I can definitely get proxy information about it. I can have information such as resistance to movement that seems to be active resistance, pulling away from a movement that is being generated by a practitioner to mobilize a patient. Quick noises, or essentially abrupt responses to abrupt movements. Those things give me an indication that there's at least a negatively valenced or a negatively directed sensation that the patient is experiencing, and I can corroborate that or coordinate that by asking them. And in most situations, for the most part, the patient benefits from answering accurately. Yeah, that hurts. Yeah, I don't like that. What I will say is that if you're going to make a claim that a particular therapeutic intervention has a positively directed or a positively valenced outcome on patients, it is very, very useful to be explicit about whether or not that is a consistent, stable, observable phenomenon that everybody would agree on, aka a physical measurement of some form, or if that is a subjective reported positive outcome. They're different things. So far, it seems as though from that particular systematic review, not all systematic reviews, but from that particular one, based on their inclusion criteria, there does seem to be a preference for subjective reporting, broadly speaking. So that seems to line up well with things that I've seen before about the preference for subjective measurements by osteopathic practitioners. There seems to be a general trend pointing in that direction. Again, there is value in that, and the researchers that do that, they are making those choices for a variety of reasons. They could be responding to the market forces of subjective sensation from the patient, possibly being deemed to predict return or lower attrition. They could be done because, again, as I said, it's less expensive to do, easier to administer, probably easier for the research subject to engage in. So those are axiological or value-based choices. But if you want to make a claim that an improvement is made by a hands-on intervention in a stable, observable way, this systematic review suggests that a better job could be done. So again, it allows me to point in the direction of likely an over engagement in the subjective experience as the marker for the success of an intervention. The success of an intervention with respect to the quote-unquote pathophysiological markers is more likely to be identified in alteration of movement characteristic, either in quantity or in quality. Those are better proxies for how stuff is functioning. It's not perfect, and I am definitely the first to critique that as not perfect, but it is the measurement that hands-on practitioners have most available. Changes in quantity or quality of movement. So I think there's value in focusing there more than focusing on the subjective experience with respect to the success of an intervention, because from the exact same stimulus that has a positively valenced or positively directed change in observable measurements, such as quantity or quality of movement, there can be a wide variety of sensations and interpretations within and between patients. So it's very easy for the practitioner to actually start to question whether or not they did something positive. It depends on the scale that you're using. The patient scale is definitely going to be more subjective and more about sensation. That is a normal phenomenon and it matters. That is a market force. That is going to impact your attrition rates. That is going to impact your earning capacity. So it is a valuable scale, but it is not a valuable scale for the practitioner to figure out if they did what they were supposed to do. The thing that you can observe, the thing that you can measure, the thing that you can interface with and change is movement quantity or quality. So I think this systematic review points in the general direction that based on what they were able to observe with their inclusion criteria, it may be highly valuable for research to move in the direction of checking those more physical measurements, those more stable, agreed upon measurements, so that maybe we can build that picture out. Again, it seems like osteopathy and other hands-on practices focus way too much on the subjective side, which is widely variable, very difficult to do anything with because you just can't sense it as a practitioner. Whereas we may benefit from really drilling down on actually making change in quantity and quality of movement, making sure that we're doing a great job of that. And then we can start to answer the questions about stable, positive outcomes with respect to sensation. So thank you for listening this far. Hopefully you learned something and we'll talk again soon.